Hello everyone, and welcome to another chapter of Advanced Pharmacology. Today we're talking about Unit 20, Drugs for the Eyes, Ears, and Skin, and we'll speak specifically on Chapter 86, Drugs for the Ear. So, in this chapter, we will discuss drugs for disorders of the middle ear and external ear. Information on the drugs discussed in this chapter is provided in Unit 18. Therapy of infectious and parasitic diseases. So, the anatomy of the ear. The ear has three major divisions: the external ear, the middle ear, and the inner ear. The primary features are as follows. The external ear consists of the auricle or pinna and the external auditory canal, a skin-lined tube that directs sound waves from the auricle to the tympanic membrane. The surface of the EAC, or external auditory canal, is coated with cerumen, or earwax, a hydrophobic substance that blocks penetration of water and helps protect against bacterial and fungal infections. The middle ear is the chamber that houses the malleus, incus, and stapes, three tiny bones that transmit sound vibrations from the eardrum to the inner ear. The middle ear is bounded laterally by the tympanic membrane, which walls off the middle ear from the external ear. The eustachian tube connects the middle ear with the nasopharynx and thereby allows air pressure within the middle ear to equalize with air pressure in the environment. The mucociliary epithelium that lines the eustachian tube sweeps bacteria out of the middle ear and into the nasopharynx. And lastly, the inner ear, which consists of the semicircular canals and the cochlea. The canals provide a sense of balance. The cochlea houses the apparatus for hearing. And here is a picture version of each of the three sections: external ear, middle ear, and inner ear. An excellent spot to hit pause if you're unfamiliar with the anatomy. Otitis media and its management. Otitis media, also known as OM, is defined as an inflammation of the middle ear. It is the most prevalent disorder during childhood. The condition affects more than 75% of children by age 3 and about 95% of children by age 12. In the United States alone, OM is responsible for more than 16 million clinical visits annually. OM may result from bacterial or viral infections or from non-infectious causes. Only bacterial OM responds to antibiotics. Furthermore, most cases resolve spontaneously, making antibiotics largely unnecessary, even when bacteria are the cause. Nonetheless, antibiotics have been used routinely. In fact, OM is the most common reason antibiotics are prescribed for children. It's an estimated cost of about $5 billion annually. So, acute otitis media. The characteristics, pathogenesis, and microbiology. Acute OM, or AOM, is defined by infection, inflammation, and fluid in the middle ear. Otalgia, known as ear pain, is characteristic, often causing the young child to tug at or hold the affected ear. Other signs and symptoms accompanying AOM may include fever, vomiting, anorexia, irritability, sleeplessness, and diarrhea. AOM results from a bacterial or viral infection of the middle ear. It occurs most commonly among children. The middle ear is filled with purulent fluid, which can cause the tympanic membrane to bulge outward. If the membrane is perforated, purulent otorrhea results. AOM commonly develops after a viral upper respiratory infection, which can cause inflammation, swelling, and subsequent blockage of the eustachian tubes. This may result in negative pressure in the middle ear, that, in turn, leads to fluid accumulation in the middle ear. When the eustachian tubes open, causing pressure equalization, bacteria and viruses can be sucked in. If the mucociliary system is sufficiently impaired, it will be unable to transport these pathogens back to the nasopharynx. OM results when bacteria colonize the fluid of the middle ear and when viruses colonize cells of the middle ear mucosa. Common pathogens here are listed in Table 86.1. So here's an excellent spot to hit pause so you can see the different types of pathogens that could trigger acute otitis media. The big ones being Streptococcus, Haemophilus, Moraxella, and then there's some others, some Streptococcus pyogenes, aureus, and some viruses, as well as both bacteria and viruses. So, how is it the diagnosis? To diagnose AOM, three elements must be present: an acute onset of signs and symptoms, the middle ear effusion, or if the tympanic membrane is ruptured, purulent otorrhea, and the middle ear inflammation. The presence of MEE, or middle ear inflammation, or effusion rather, is indicated by the limited mobility of the tympanic membrane on pneumatic otoscopy, or tympanometry. Middle ear inflammation is indicated by either distinct erythema of the tympanic membrane or distinct otalgia. It is important to distinguish between AOM and otitis media with effusion. As discussed later, children with OME have fluid in the middle ear, but no signs of local or systemic illness. Prolonged OME is common after resolution of AOM. So the standard treatment: all children with AOM should receive pain medication, and some should receive antibiotics. Prescribing antibiotics, however, for all children should be discouraged because most, over 80%, of AOM episodes resolve spontaneously within a week. If antibiotics are prescribed routinely, most recipients will be taking drugs they don't really need. Not only does that generate unnecessary expenses, worse yet, it puts children at needless risk for adverse drug effects, increasing their risk for recurrent AOM and accelerate the emergence of antibiotic-resistant bacteria. In 2013, the American Academy of Pediatrics released guidelines for treating AOM in children. These build on earlier guidelines developed jointly by the AAP and the American Academy of Family Physicians. For many patients, the guideline includes an important option, which includes observation, rather than immediate treatment with antibiotics. Observation is defined as the management of symptomatic relief alone for 48 to 72 hours, thereby allowing time for AOM to resolve on its own. If symptoms persist or worsen, antibacterial therapy is then initiated. As part of the strategy, parents are informed about the high probability of spontaneous AOM resolution and the drawbacks of giving antibiotics when they aren't needed. Observation is considered appropriate only when a follow-up can be ensured. The recommendation for observation is based on studies showing that the following: most episodes of AOM resolve spontaneously. Immediate antibacterial therapy is only marginally superior to observation at causing AOM resolution and is no better at relieving pain or distress. Parents find the observation approach acceptable. And lastly, delaying antibacterial therapy does not significantly increase the risk for mastoiditis, which can occur when bacteria invade the mastoid bone. So here is a criteria for antibacterial treatment or the observation in children with uncomplicated AOM. It's an outstanding spot to hit pause so you can take a look and see whether or not a patient needs antibiotics or not. Criteria for choosing between observation and the initial antibacterial therapy again are shown here on this table. As indicated, all children younger than 6 months should receive antibiotics, regardless of diagnostic certainty or symptom severity. Among children 6 months to 2-year-olds, antibiotics are indicated whenever the diagnosis is certain. And for children 2 years and older, antibacterial therapy is indicated only if the diagnosis is certain, and then only if the symptoms are severe. In all other cases, observation is the preferred strategy. So here is that table they were talking about: criteria for choosing initial antibacterial therapy versus observation in children with acute otitis media. Again, there's a good spot to hit pause just to kind of read over it and review it. When antibacterial drugs are indicated, high-dose amoxicillin is the treatment of choice. Benefits of amoxicillin are efficacy, safety, low cost, acceptable taste, and a narrow microbiologic spectrum. The duration of treatment ranges anywhere between 5 to 10 days, depending on the patient's age and the illness severity. So again, here's another good spot to hit pause because it tells you the recommended antibacterial drugs for acute otitis media. For patients who have a penicillin allergy, drug selection depends on allergy severity. If the allergy is not severe, a cephalosporin may be used. However, if the allergy is severe, cephalosporins should be avoided owing to the concern of a cross-reactivity. In that case, azithromycin and clarithromycin are recommended. Regardless of whether antibiotics are prescribed, pain management must be included when treating AOM. Analgesics may include Tylenol or ibuprofen, which are commonly used to manage mild to moderate pain. For moderate to severe pain, codeine or a similar drug may be necessary. For children older than 5 years of age, the 2013 AAP guideline also recommends a topical anesthetic, such as Procaine or lidocaine drops for pain relief. The 2013 guideline also recommends benzocaine. However, because it lacked the FDA approval, the FDA required its removal from the market in 2015. In Canada, however, benzocaine is still available for this purpose. An example is antipyrine and benzocaine. Both antipyrine and benzocaine are local anesthetics. So to relieve pain, the EAC is filled with a solution, and then the solution-soaked cotton pledget is placed in the EAC to prevent drainage. This typically needs to be repeated every 1 to 2 hours until the pain is relieved. It's contraindicated if the tympanic membrane, however, is perforated. Treatment of antibiotic-resistant AOM. Antibiotic resistance is indicated by persistence of symptoms, whether it's a fever, earache, otorrhea, or red or bulging tympanic membranes, for 2 to 3 days despite antibiotic therapy. Major risk factors for developing a resistant AOM are the following: daycare attendance, age younger than 2, and exposure to antibiotics in the prior 1 to 3 months, and whether or not it's winter and spring season. Again, in the US, the incidence of resistance or resistant AOM is currently on the rise due to the overuse of antibiotics, which has favored emergence of resistant pathogens. Resistance among strains of Haemophilus influenza and Moraxella catarrhalis is limited to beta-lactam antibiotics. The mechanism is production of beta-lactamase, an enzyme that inactivates amoxicillin and certain other beta-lactam antibiotics. In contrast, strains of Streptococcus pneumonia are resistant to multiple antibiotics including erythromycin and trimethoprim sulfamethoxazole, as well as amoxicillin and other beta-lactam antibiotics. Interestingly, S. pneumoniae resistant to amoxicillin does not result from a beta-lactamase production. Rather, it results from the synthesis of altered penicillin-binding proteins, whose affinity for amoxicillin is much lower than that of normal penicillin-binding proteins. So, how should resistant AOM then be treated? Using a high dose of amoxicillin increases activity against resistant S. pneumoniae for H. influenzae and M. catarrhalis. The preferred approach is oral therapy with a high dose of amoxicillin clavulanate. The clavulanic in the combination inhibits beta-lactamase and therefore increases activity against resistant H. influenza and M. catarrhalis. Because the clavulanic is in the combination can cause, however, diarrhea. So the dosage of clavulanic should be low. It's important to be aware that the ratio of amoxicillin to clavulanate is not constant. So for example, Augmentin is available in a tablet that contains 250 milligrams of amoxicillin and 125 milligrams of clavulanate, and as tablets containing 500 milligrams of amoxicillin again with 125 milligrams of clavu- clavulunate. If tube tablets containing 250 milligrams of amoxicillin are administered to give a patient a 500 milligram dose of amoxicillin, the excess of clavulanate can result in a worsening of diarrhea. Alternatives to amoxicillin slash clavulanate includes intramuscular ceftriaxone and oral clindamycin. All three regimens are recommended for children with acute AOM that has not responded to the standard antibiotic therapy, or if the initial therapy of AOM in children with risk factors for resistant infection. So, prevention. The risk for acquiring AOM can be decreased in a couple ways. Breastfeeding for at least 6 months seems to reduce early episodes of AOM. During infancy and early childhood, AOM can be significantly reduced by avoiding childcare centers, and if possible, when respiratory infections are prevalent, measures believed to help prevent AOM include eliminating exposure to tobacco smoke, reducing pacifier use in the second 6 months of life, and avoiding supine bottle feeding. Two additional measures are prevention and treatment of influenza and vaccination against a pneumococcal infection. Prevention and treatment of influenza. Again, as noted, influenza and other viral infections of the respiratory tract predispose children to developing bacterial and viral OM. Accordingly, measures that reduce influenza can reduce OM risk. Two methods are available: vaccination against influenza and the treatment of active influenza infection. Although both immunization against and treatment of influenza can help during the flu season, they do not alter anything in AOM risk the rest of the year. Vaccination against Streptococcus pneumoniae. Vaccination with pneumococcal conjunctive vaccine can reduce the risk for AOM. Of note, as pneumoniae was once responsible for 40 to 50% of bacterial AOM. This, however, has decreased significantly since the first PCV was introduced in 2000. Unfortunately, now there has been an increase in strains that are not included in PCV. So, that now takes us to recurrent otitis media. Recurrent AOM can be defined as AOM that occurs 3 or more times within 6 months, or 4 or more times within 12 months. There's 4 management strategies that are available: short-term antibacterial therapy, prophylactic antibacterial therapy, prevention and treatment of influenza, and finally the placement of a tympanostomy tube. So, speaking on each one of those options, short-term antibacterial therapy. There is disagreement among experts regarding antibacterial therapy. Some authorities recommend antibiotics for each recurrent episode, regardless of presentation. Others, however, recommend reserving antibiotics for episodes in which symptoms are severe. In both cases, high-dose amoxicillin is the treatment of choice. If resistance is suspected, then the combo drug amoxicillin clavulanate can be utilized. The prophylactic antibacterial therapy. Antibacterial prophylaxis is not generally recommended. An analysis of several studies indicates that for each year of prophylaxis, only 1.3 episodes of AOM are actually prevented. This small benefit is largely outweighed by the risk of promoting antibiotic resistance. If prophylaxis is elected, it should be conducted only during the upper respiratory infection season. The preferred drug for prophylaxis is amoxicillin, because compared to sulfonamides, amoxicillin is more active against multi-drug resistant strains of S. pneumoniae. Preventing and treating of the influenza. As discussed previously, AOM occurrences can be reduced via vaccinating against the influenza virus and by treating active influenza infection. However, benefits are only seen during the flu season. And again, lastly, the tympanostomy tubes. A tympanostomy tube permits drainage and aeration of the middle ear. Tube insertion is performed under general anesthesia. In children with recurrent AOM, the procedure can significantly reduce AOM episodes. Complications of the procedure, however, include obstruction of the tube, secondary infection with otorrhea, and premature tube extrusion. Otitis media with effusion, so OME, is more common than AOM. It often occurs with upper respiratory tract infections and may precede or follow an episode of AOM. The condition is characterized by fluid in the middle ear, but without evidence of local or systemic illness. OME may cause mild hearing loss, but no pain. The condition can persist for weeks to months after AOM has resolved. Because it is not caused by a bacterial infection, antibiotics have no effect on OME and should not be used. Which brings us now to otitis externa and its management. Otitis externa is the inflammation of the EAC. The usual cause is bacterial infection, which may be limited to the EAC or may spread to adjacent tissues. Most cases of OE or otitis externa respond to topical drugs. So, acute otitis externa, its characteristics, pathogenesis, and microbiology. Acute otitis externa, also known as swimmer's ear, is a bacterial infection of the EAC. The most common pathogens are Pseudomonas aeruginosa and Staphylococcus aureus. However, other pathogens include a Staphylococcus epidermidis and Mycobacterium otitis. Patients who have AOE present with one or more of the following: a rapid onset ear pain associated with pruritus, a sensation of ear fullness, tenderness or manipulation of the external ear, or edema or erythema of the EAC. Impaired hearing and purulent discharge may also occur. Susceptibility to AOE is precipitated primarily by two factors: abrasion and excessive moisture. Both facilitate bacterial colonization. Abrasion of the epithelium creates a site for bacterial entry. Most often, abrasion results from cleaning or scratching the EAC with a cotton-tipped swab or some other foreign object. Abrasion can also be caused by hearing aids and earplugs. Moisture can wash away the protective layer of the cerumen. As a result, keratin debris in the EAC is able to absorb water, thereby creating a nourishing medium for bacterial growth. Moisture in the EAC may come from swimming, perspiration, and even high humidity. So its treatment. AOE is a painful condition, often severely so analgesics are indicated. The same analgesics that were used for AOM are appropriate for AOE pain management. AOE usually responds well to simple treatment. The goal is to eradicate the pathogen and reduce pain. For most patients, cleaning and the use of topical antimicrobials will suffice. If the infection is extensive, oral antibiotics may be necessary. To facilitate healing, the ear should be kept as dry as possible. Most affections begin to improve within 3 days and resolve entirely by 10 days. So, are topical medications therefore? The most recent 2014 AOE clinical practice guideline, published by the American Academy of Otolaryngology, recommend topical antimicrobials over systemic drugs for uncomplicated AOE. There are two reasons for this recommendation. First, topical agents achieve very high local concentrations, antibacterial effects are superior, disease persistence is lower, and reoccurrence is less likely. Second, the topical therapy. Systemic side effects are absent. Exceptions are made for patients with diabetes, immune deficiencies, or those who would have difficulty with proper administration of topical drugs. These patients should have systemic therapy. Systemic therapy should also be prescribed if the infection has spread beyond the EAC. In severe cases, both systemic and topical antibiotics may be necessary. So here is that guideline. It's an excellent spot to hit pause so you can review the management of acute otitis externa. A variety of topical medications may be used. There's a 2% solution of acetic acid, which is safe, effective, and inexpensive. A solution of alcohol plus acetic acid offers the additional benefit of promoting tissue drying. For many patients, acidification and drying is all that is necessary. If the infection is more extensive or cannot be cleared with acetic acid and alcohol, a topical antibiotic should be employed. In the past, a three-drug combination, hydrocortisone, neomycin, and polymyxin B, was considered standard therapy. The hydrocortisone reduced the inflammation and edema. Neomycin and polymyxin killed bacterial pathogens. Unfortunately, although this combination is effective and also inexpensive, it had drawbacks. Specifically, the neomycin component is ototoxic and causes local swelling and erythema in about 15% of patients. Today, quinolones or ciprofloxacin are preferred because these drugs are highly effective and they don't cause any kind of local reactions and are also not ototoxic. Unlike many otic preparations, quinolones and quinolone glucocorticoid combinations are safe for patients who have perforated tympanic membranes. The glucocorticoids has the added benefit of decreasing pain by reducing swelling caused by inflammation. Options include Cipro-HC, Ciprodex, and Floxin-Otic. Principal drawbacks of these preparations are the expense and the potential to promote a resistance to quinolone antibiotics. Applying eardrops correctly can also improve outcomes and reduce drug-related discomfort. Installation of cold solutions can cause dizziness. Therefore, eardrops should be warmed before administration. Wiggling the earlobe, if tolerated, can also facilitate transit of solution down the EAC. If edema results in EAC closure that is sufficient to impede drug penetration, insertion of a wick can also help. A wick is like a very tiny elongated tampon. After it is carefully inserted into the edematous EAC, eardrops are applied to the exposed tip. Drug solutions are absorbed into the wick, which then delivers them to the epithelium of the entire canal. The wick should be replaced at least every 48 hours to allow cleaning and to determine whether further wickening is still needed. Which takes us now to oral antibiotics. Oral antibacterials are indicated if the infection extends beyond the EAC to involve the pinna. For adults, ciprofloxacin is a good choice. However, because oral quinolones can cause tendon rupture in younger patients, it should not be given to a patient that is younger than 18. So for children, cephalexin is preferred. So here's a good spot to hit pause so you can read over the patient education on prevention. The big things is don't put anything in your ear, which would include cotton swabs, um, and don't remove the cerumen or earwax, and don't use earplugs when swimming. So that brings us to our next section, necrotizing otitis externa. Necrotizing OE is rare but potentially fatal complication of AOE that develops when bacteria in the EAC invade the mastoid or temporal bone. Spread of the infection to the skull base can affect cranial nerves and spread to the dura mater, which can cause meningitis and possible lateral sinus thrombosis. The usual pathogen is P. aeruginosa. Patients typically present with progressive severe otic pain, purulent discharge from the ear, and granulation of the tissue in the EAC. Necrotizing OE occurs almost exclusively in two groups of high-risk people, specifically older people with diabetes and people who are immunocompromised, especially those who have HIV infections. All patients should receive anti-pseudomonal eardrops, along with oral ciprofloxacin. Referral for a specialist care should also be considered. Progression to severe disease will likely require IV anti-pseudomonal therapy for at least 4 to 6 weeks. Fungal otitis externa, also known as otomycosis. In about 10% of patients, OE is caused by a fungi and not bacteria. The two most common pathogens are Aspergillus, which causes 80 to 90% of otomycosis. The other would be Candida. Fungal OE typically manifests as intense pruritus and erythema, with or without pain or hearing loss. So as a rule, otomycosis can be managed with thorough cleaning and application of acidifying drops. If these measures are inadequate, the patient can apply a solution that contains an antifungal drug, such as a 1% clotrimazole, twice daily for at least 7 days. If the infection fails to respond to oral antifungal therapy, may be necessary, which would include itraconazole and fluconazole. So, prescribing and monitoring considerations. The therapeutic goal. The goal of management of ear infections are to reduce inflammation, eliminate its infection, and prevent complications due to either AOM or AOE. Complications again include the development of language problems, secondary to hearing deficits, and development of drug-resistant bacteria. Rare but serious complications of AOM include mastoiditis and meningitis. Again, as noted, necrotizing otitis externa can occur from an extension of AOE. So, identifying our high-risk patients. Again, you want to assess for penicillin allergy before prescribing amoxicillin or amoxicillin clavulinate. Patients who have experienced a mild reaction to penicillins, guidelines recommend a cephalosporin, such as cefdinir, cefuroxamine, or cefpodoxamine. For severe reactions such as anaphylaxis, azithromycin and clarithromycin is recommended. Determine whether the patient with AOM has taken amoxicillin in the past 30 days. If so, the combo drug should be prescribed. This should also be done if H. influenza or M. catarrhalis is suspected. Other considerations is have there been 3 or more episodes of AOM in the past 6 months or 4 times in the past year? If so, consider referral to an otolaryngologist. Tympanostomy tubes may be indicated, especially if hearing loss is a concern. Is the tympanic membrane still intact? If not, avoid ototoxic drops. Again, there are aminoglycoside preparations that you should not use. Instead, prescribe a quinolone or a quinolone glucocorticoid combo drug because those are safer for the patient that have a perforated tympanic membrane. Another consideration is for AOE if the canal is significantly swollen. Insert a Vic to ensure that the medication reaches all affected tissues. And lastly, patients with AOE who have diabetes or immune deficiencies should receive systemic therapy or a combination of systemic and topical therapy. Systemic therapy or a referral is indicated if the infection has spread beyond the EAC. And then ongoing monitoring and interventions. Patients with both AOM and AOE should have improvement in 48 to 72 hours. Before leaving the clinic, they should be instructed to return if they do not have an improvement or if their condition starts to worsen. Keep in mind that MME will continue long after AOM has resolved. For this reason, tympanometry and pneumonic otoscopy will not reflect a normal response to pressure changes for several weeks or even months. And finally, if young children with recurrent or prolonged AOM experience language problems, consider early referral for intervention. And that concludes our chapter here for today. I thank you as always for listening, and I hope you have a wonderful day. Take care and goodbye.